This is episode 139 of the Rio Grande Foundation's Tipping Point, New Mexico podcast. I'm Paul Gessing, president of the Rio Grande Foundation, New Mexico's free market think tank. You can find out more about the foundation at riograndefoundation.org. I am very pleased to be joined this week by Stephen Muhr. Stephen is a physician's assistant from Pecos Valley Wellness in Roswell, New Mexico, and he's got a unique model for providing healthcare services to New Mexicans. And we're going to talk a little bit about that, his business, and just kind of healthcare in general in the state of New Mexico. But Stephen, welcome to Tipping Point, New Mexico. How are you doing today?
Very good, Paul. Thank you.
Yeah, so talk a little bit about yourself and Pecos Valley Wellness there in Roswell.
I've lived in Roswell a long time. I started out as a school teacher, and always had health insurance at that time. But whenever I was sick, I could never keep a provider. The providers were always turning over, and things just was kind of a frustrating thing. I'd even make an appointment to go set up with a provider, and then a few months later I would get a letter that said, your provider has moved, and so you don't have one anymore. And so that was always kind of something that happened, and I became interested in medicine, and because of my family and so forth, I decided to become a physician assistant, and went off to Nashville, Tennessee, went to school, and ended up coming back to New Mexico and becoming a family practice provider. I did that probably 7 years before I came across this model. And this model is basically, it's primary care. It just doesn't have all the hassles that were created by insurance. That was probably causing a lot of the reasons why I could never keep a provider when I was a school teacher. So that's
so there's
where we got started.
There's a lot to unpack. I mean, anytime you get into healthcare, boy, you can go a million and one different directions. But talk about your practice a little bit. You're a physician assistant. So briefly, what does that mean as opposed to, say, a physician?
Okay. A physician assistant is, we go to school and we basically learn the medical model that doctors learn. It's very condensed and very fast, and pretty stressful. But we end up with around 116 hours of medical science credits, and a whole year of rotations that are full time, so about 2,000 hours in hospitals and clinics. And then when we get out, we work usually with a supervisor to start off with, and that is a doctor, and we continue to work on our craft as a medical provider. Here in New Mexico now, they've allowed us to be able to move towards a collaborative status, which is kind of a new thing in the country. New Mexico is usually one of the better states for a physician assistant to practice in. And so if you've been working in primary care for more than 3 years, you can move into a collaborative physician assistant status, which means that you may not have the doctor in your office with you all the time, and you may not be doing family practice with you, but you have someone that you collaborate with, and you can collaborate with a lot of different doctors if you want to. But after 7 years, and then the law changed, and I went ahead and decided to do that. And there were a lot of other physician assistants and nurse practitioners who own their own clinics in town, but none of them were really. They were all pretty much doing the same thing that I was doing and looking for someone else in the clinic. So I kind of found a new model to start working under that I really enjoy.
Yeah, so it's a unique model financially, and it goes kind of outside of the traditional insurance and Obamacare model, and it's definitely taken off. It's, as far as I know, the primary way to describe it is direct primary care. So why don't you talk about how direct primary care works from your end, which is the provider perspective?
As a provider, yeah, direct primary care really is a fairly good description. I try to provide everything directly to my patients. So I try to take out the middleman as much as possible. So even to the point where I really don't have a front desk. That's really hard for patients to get used to. That they really are contacting me to tell me what they need, and if they need an appointment, or they need a medication, they need any other type of basic medical care, then they have my telephone number and they can do that. And so, but then also they're paying me directly. I'm not billing some kind of insurance system to try to get paid for the services that I provide. And so, so I'm telling my patients that I'm going to try to see them the same day or the next day, and that they can contact me directly if we can take care of things over the phone. Then we will do that. And so each of my patients end up paying a membership per month to get those kinds of services.
Now, are you primarily working with individuals, or say a small business signs up their employees for this kind of direct care, or is it just all of the above? And walk through a little bit without going into all the details, just what kind of folks might be attracted to this kind of care.
Well, the answer to that question is really all of the above. I have small businesses that buy memberships for their employees. They'll pay the membership and they'll have the employee. And one thing that I guess I have to add to this is that I dispense medications from my office that is legal for us to do in New Mexico. And so employees can come to my office and get way better prices on their medication than if they're trying to buy those for cash in the pharmacies. And so, and I cover quite a few meds like blood pressure medications and antibiotics and other things that people may need throughout the year. I can often provide them at a much lower cost because I choose to pass the savings on to the patients that way. And so that's one benefit of membership. I also have the same thing for laboratory. So the labs are 80 to 90% cheaper than if they went to most of the other labs in town. And so that's part of it. For families and individuals, it's very similar to the same thing. So oftentimes a family of mom and dad and two kids, that's about $120 a month for my services. And I usually get called on somebody once a month at least. And so we're able to do that and get them in and get things taken care of and get them back out the door and back into their life.
And so you would see somebody. It's like a subscription service, as far as I'm aware, and you have full-fledged, doctors who do this model nowadays. You have a large number, a growing number, I guess, of medical professionals going under this model. What do you think are the primary benefits and any drawbacks to the direct care model?
The first drawback is usually going to be finding people coverage for specialty services in hospital. That's usually hard. We don't have insurance structures for people to be able to buy insurance policies, especially in the state of New Mexico, that would, just be a catastrophic policy where this is for when you need to go to the hospital. So that's usually one of the harder things to deal with. But for the most part, a lot of people are going around without any kind of plan for their health care at all. So we're providing primary care where we can do things to keep them out of the hospital, as long as they don't have accidents that we can't handle and things like that. Then, so they're able to control their blood pressure, they're able to see what their cholesterol is, they're able to do the things that make them healthier and hopefully, reduce their need to go to the hospital, or at least delay it out later in their life. And so that's part of it. I mean, study after study has shown that access to primary care is way more beneficial to the population than all of the specialty services that we have as far as longevity and so forth. So I'm a primary care advocate, and that's a big part of it. And so that's probably the big one. Whereas everything else that makes you frustrated about healthcare, we've taken care of. So we don't have copays, we don't have prior authorizations to get the medicines. We have the labs for an affordable price. We don't ever tell you it's going to be 2 weeks before we can see you. We even, I'm known to get up and off the couch and come down here to stitch people up when they contact me, and that sounds like something that they need. And so also, I was just at a conference, and they were talking about handicapped people not being able to get in and see why. I often see people at the house. Insurance doesn't like to pay for home visits. I don't care. I'm not relying on insurance to pay me anything. So I can make home visits and see people where they're most comfortable. And so that gives me a lot of satisfaction, and gives the patients a much easier and more enjoyable experience in healthcare.
So unlike most doctors who are working for arguably, and correct me if I'm wrong, a combination of insurance companies and government programs like Medicare and Medicaid, you truly are working for the patients themselves. You have patients that pay you directly, so those are the people you cater to. Am I off base with any of that?
No, you're right. That's exactly it.
And this, without, go ahead.
I've had patients, who have told other providers, hey, I waited out here for 3 hours. Do you think that I don't have time that I needed to be working today? And so, that's, it might be a headache to some of the more traditional providers, but in a lot of ways that's true. It's always been, well, you just have to deal with this. And I often apologize all the time because I'm, 8 minutes late getting into the room. I don't have a waiting area. I really want people to be able to come to their appointment on time and leave on time. And so that's pretty important.
Now, did you ever work under the traditional healthcare model, or is this pretty much the way you've always done things, is with this direct primary care?
Yes. Yeah. I worked under the traditional model for 7 years. And so in the traditional model, I had to at least see 20 people a day. And so oftentimes you find yourself seeing people who probably didn't need to be seen. But they need to be, in order to keep their status, we need to be able to see 20 a day to stay open and to be able to. So we're billing people for, come back in, it's time for you to get a refill on your blood pressure medicine and things like that. And everyone has dealt with that. If you're on chronic medications, everyone's dealt with that situation. I don't know, I just saw a doctor 3 months ago, but I have to make another appointment and take part of the day out of work to go in to get a refill on my blood pressure medication. And that's why, because if if we don't see that many people, then the office can't stay open.
Yeah, and of
and that's
course
kind of the rule of thumb.
the time cost is
Go
part
ahead.
of that, but the actual cost to the patients is significant because you're paying money for a service you really don't want or need, but you have to pay for that service in order to get what you actually want, which in many cases is a prescription or some kind of medicine that you need. So, uh, you know, did you deal with a lot of government programs? People seeing you through those government programs, and just anything about the payment mechanism, the bureaucracy, uh, how that all worked, and how that was to deal with during those 7 years when you were working in the traditional system, and any comparison with how it works now.
Well, it drove everything. Billing, the way it's billed, putting the right codes in, making sure that you've noted the right things into your chart so that it can be billed at the highest degree, becomes pretty important. And then of course you order something, and now the patient, or the pharmacy calls you back the next day. That patient didn't get the medication you ordered because their insurance won't cover it. So you either need to do a prior auth, which is a lengthy process of sending faxes back and forth to the insurance company to get the medication approved, or you have to pick a different medication to send out for that patient to take. So yeah, you were constantly, having to determine what do I have to do, get all the ducks in a row to be able to please the insurance company, so that the patient can get something that I think they need. So you had a whole lot of things between you and the person that you're caring for, and a whole lot of things affecting your decisions.
No doubt about it. Now, of course, I'm the policy guy, so to speak, and I'm sure you have plenty of opinions. You probably have more than most doctors because you chose to do something a little differently outside the box. But our view at the Rio Grande Foundation, being a free market think tank, is that your model, direct primary care, is a lot more along the lines of what healthcare should look like across the entire spectrum, mostly in terms of the relationship between patients and their doctors, the direct relationship that primary care, the oil changes, if you will, taking the metaphor to automobiles, that stuff should be definitely paid for out of pocket, that you should be involved in having that direct relationship as a doctor and a patient, and that insurance should be for I get hit by a car, I get some horrible sickness like cancer or some other disease, and those kinds of issues that I know your model is you send those people into the hospital system or other ways of being treated, but your effectiveness is often determined by heading off those conditions before they happen, because people don't like to attend doctors because they're, of all the reasons we've been discussing. So how do you see your model as being kind of the path forward for American healthcare, if we're ever going to get a handle on this? Or what's your take on maybe that broader healthcare debate?
Yeah. I do, and I think that way more could be done besides primary care in this model. I do know that there are doctors out there experimenting. I know that recently, an OBGYN did an entire for another direct care doctor. He did a direct care delivery for the family. Where they paid out of pocket for the whole thing, and that's considered one of the most expensive and cost loss areas in medicine is OBGYN care. Hospitals notoriously never make money; they only lose money on that. And so so someone is actually working on that, and that's, I think that a lot of these would benefit immensely. From looking at what is this really about, and I often try to tell people somehow, in the last decade, they made people believe that having a card in your wallet was healthcare. And, like I said, I had a card in my wallet for years, but could never manage to make a relationship with a provider. And so that's, that's really where healthcare happens, is when you have somebody that and they are ready to take care of you when you need it. And that's what we're trying to provide.
Yeah. And you mentioned babies and OBGYN and that kind of thing. And, having babies is, I'm a man, you're a man, but we have, my wife and I have three lovely daughters, and it's not been so long that I don't remember that entire process. And of course, having babies is very expensive. I certainly remember that part of the process. At least it's expensive in today's medical system. Now, do you have any idea why that gets so expensive when there are a lot of women out there who are doing home childbirths and other kinds of things? What drives the cost? Sorry?
Well, a lot of the cost there is in malpractice. That's always driven costs up. And so we're talking about, people's dreams and hopes and aspirations and having a child, and something goes wrong. And so now we're looking for a lawsuit. And so that's, and that's sometimes very understandable. But that drives, in that one, that's one of the highest costs, is paying for the malpractice insurance for those providers. The rest of it, I'm not sure. The prices that hospitals come up with to charge tickets, when I look at what I pay for those same things, I don't, there's a huge amount of profit going in there with, on that particular thing, what they charge per diaper or whatever. So, anyway, but the biggest one in that case is most likely the malpractice insurance first, and then staffing and everything else that it requires to. After that, I would say probably staffing to bill insurance is such a huge cost in most cases.
Now, why is that? Talk about that. Obviously, we know that the office staff and all those people cost money, and submitting paperwork costs money. Insurance is one part of that puzzle, but of course, you've got government entities that you're dealing with. Is it just the shuffling around of paperwork? Is it the staffers themselves? Because, hey, you look at the salary of a doctor versus the salary of an office staff, and I've got to expect that the doctor's salary is a lot higher than any individual office staffer. So share that whole approach and that issue.
Yeah, it is. They are. But yes, it is. It's just a lot of paperwork and follow up that has to occur. Again, insurance companies then say, "Well, we don't want to pay for what this doctor, how this doctor practices, whether it's these labs that they want to order or whatever." So someone's got to get on the phone and get those approved for people. As my personal experience working, I counted a lot of staff people, and $10 to $15 an hour starts adding up quickly as you start counting people that are working desks, collecting co-pays and making copies of insurance cards, and people that are doing referrals, trying to get people to the specialists that they're supposed to go to, and then the actual people who are actually writing all these codes down on, or putting them in the computer to have them billed to each individual company, which has its own quirks, depending on who you're dealing with. So it ends up being a significant deal. And then if you're going to give those people benefits and everything else, you're looking at 30% of your income going to that sometimes. So, so that's, yeah. And that's another thing that has been really disturbing is many doctors don't want to run an office anymore. They want someone else to run it for them, and they'll just work as an employee. And I think there was a big loss there for the country over the years, because now healthcare is being driven by non-medical people.
Right.
So that's a concern.
So if you had, wave your magic wand here, Stephen Muhr, and tell us what you would do to American healthcare to make it work like it's supposed to.
Well, like I said, I think that, whenever we started, I would have had more options, more competition for, hospital insurance, catastrophic insurance, those kinds of things. And like you said, primary care really can be paid for quite affordably for people, and they'll get a better responsive care, from the medical community, doing it that way. So you're not seen as a Blue Cross Blue Shield walking in the door, you're seen as Mr. Smith walking in the door. And so, that would make a big difference. But having better choices for insurance for people when they have to, take advantage of this. And I don't want to run down the specialties. I mean, we have fantastic specialists out there that do amazing things, and people travel here from other countries to get the best specialists in the world, and I don't want to lose that. So I think that having insurance models that allow us to access those people when we need them would be good. And then I think the market plays pretty well, especially in a lot of these cases, and probably can expand even further than just primary care. But that's really what I was hoping for. Instead, we mucked up primary care, and we really made the quality of whatever insurance we had before go down, and costs went way up for everybody who was trying to take care of their health care on their own.
Got it. And one last question I have to ask, because I think from a political perspective, talking more, just straight up politics, this model, and traditionally doctors used to be pretty conservative folks. It's evolved since then as it's left the entrepreneurial kind of yeoman individual doctor, and now they're much more organization people working for somebody else. But I know you're a conservative guy, free market guy. Was it 7 years in traditional medicine that made you more conservative, or did you start out, in that general perspective politically, and then maybe eventually you were finally able to go in a direction that you actually saw fitting your own values and philosophy? Talk about the interplay, I guess, if you will, between your own political philosophy and your medical practice.
Well, I've always been pretty conservative. I've been a person of faith, and felt that I was supposed to work with people in this world, make the world a better place. And so when you feel like the patient and you are working for a company that an insurance company or the government, which is so intertwined in all of this as well, I really just was probably, even as I went through my clinical rotations, as a student, I was like, this is there's got to be a better way to take care of people than this. And what things are we doing that actually are creating bad habits for people and poor attitudes about their health care that are rather damaging and really hard on society as a whole. So, that, I guess that's kind of where it came from. So, no, I've always been more of a conservative. Let's give people some freedom. Let's let people solve problems in local communities and see what happens and see if we can share these things with each other and become better. And that's been really gratifying. I think I was one of the first 100 clinics to sign up with the company that I use that helps me run my practice. And now, they just announced a few weeks ago that there's 600 clinics that are using it. And I've been doing this with them for, I guess coming on to 3 years or so. But so it really has exploded, and you're seeing the potential for this is out there. And it's just, worrying about, what's the government going to do, that will, because, things like not recognizing if I don't, bill their insurance, then, they won't accept, a referral from me. The insurance company, if one of my patients has insurance and they need to go get an MRI, I can't order the MRI because I'm not billing the insurance as the PCP. Those sorts of things make me nervous. And there are organizations out there that, private physician organizations that are working on those issues, but we still see in the grand scheme of things compared to, insurance companies, and we don't have that kind of weight to throw around, I guess, would be some of the things that have me concerned. But overall, I'm real positive about, what's happening and the potential that,
Well, Stephen,
hopefully we can help our patients.
Thanks for taking some time out of your schedule today. How do people find out about Pecos Valley Wellness if they're in the Roswell region and they want to be your patient?
They can go to pecosvalleywellness.com, and there's a website there. They can even sign up through there. We usually take a look at things, give them a call, and make sure that it's going to fit before we really nail them down as a patient. So there's not a lot of things to worry about. They can call me 575-291-9814. I can usually help them with that as well.
All right. Well, thank you very much. And I appreciate those who listen in today for this week's podcast. Make sure to get the latest edition of Tipping Point, New Mexico by subscribing at Apple Podcasts, Stitcher, and Spotify. You can post or comment on this and other episodes on Facebook and Twitter, and tell Google Home to play Tipping Point, New Mexico. Thanks to Path 3 Marketing for producing this show.